Okay, technologies in order. My name is Helena Warrenco. I'm on the executive board of Ocamper, and I have the pleasure today of introducing our workshop leaders, whose topic is the role of medicine and spiritual care in combating loneliness. Mina Magelli is a licensed physician, family physician at McCowan Medical Center and Healthcare Plus. Bavli Kost has a certificate in spiritual care and psychotherapy, spiritual care practitioner at Scarborough Health Network, and private practice of psychotherapy. Both gentlemen are members of the St. George Coptic Orthodox Church and have come from Toronto, Canada to share their impressions with us. So please welcome Mina and Bavli.
Thank you, Helinda, for the very nice introduction. So Bavli and I are coming from our tropical island to tell you guys about loneliness and the role of medicine and spiritual care in combating loneliness. So first we're going to speak very broadly about loneliness, and then we're going to hone in on one of the patients that Bavli knows, and her name was Stacy, and she was going through a pregnancy and then a termination of the fetus, and we're going to talk about her journey and her loneliness during her stay in the hospital. First and foremost, loneliness in America. There is a group called Action for Children based here in Chicago, and it deals with the needs of impoverished children and underserved children specifically. And they surveyed their parents, and 24% of the parents surveyed said that they were always or often lonely. And always or often was underlined, and because you could easily ask someone, well, do you typically feel lonely? And most people feel lonely every once in a while, so that wouldn't be very clear. But always or often lonely is specific. It shows that almost a quarter of these parents are in a persistent state of perceived social isolation. The General Social Survey is an annual psychosocial survey that's done starting from 1972, and they found that the number of Americans with no close confidants has tripled since 1985. 0 is the most common number of confidants reported by a quarter of those surveyed. And in the United Kingdom, they found that 23% of people, again, say always or often lonely, and they lack companionship or they feel isolated. So the trend is a quarter of adults seem to be lonely or at least have perceived isolation. Bavli will talk more about Stacy's story. It's a pseudonym, by the way. Her name isn't actually Stacy. So the objectives of this talk is identifying loneliness, who is prone to loneliness, what health effects are associated with loneliness from a medical perspective, what is the academic approach to an isolated patient, and what can we do as the Orthodox faithful. On my way in here in the airport from Toronto to Chicago, I was reading an article in the Canadian Family Practice Journal, and the writer was basically talking about pain that we do not know how to deal with. So after you've talked to your patient and you've tried various medications and tried various therapies, he's still having pain, and he says, "Doc, I'm in pain." So how do you deal with that? And his conclusion was, well, you have to have a conversation with your patient, listen to them, and essentially just sit back and listen and take it in as another observer of someone's pain. And then he said, this is certainly not nothing, which is a very important thing. So who is susceptible to loneliness? Extroverted people and people with type A personalities both require other people. So they both need an active audience. So when there is no active audience and when they're isolated, they perceive loneliness more than people who are introverted, for example. Single men tend to be more prone to loneliness. Genetic predisposition. There are various personality disorders that make you prone to loneliness. Addiction to social media makes you feel lonely. Yesterday, His Grace was talking about voluntary versus involuntary isolation, and that this is a form of voluntary isolation, but it is, he said that it was a stripping of your free will, stripping of your freedom, which is God's greatest gift to us. The chronically ill are more susceptible to be lonely, those who think they can deal with loneliness without getting other people's help. So why is speaking about loneliness so important? It's a worsening epidemic. There are a wide variety of health concerns, including coronary arterial disease, decreased immune function, and overall increase in mortality. Again, social media is contributing to loneliness and depression. There's a wide variety of mental issues with loneliness, including suicide, depression, even worsening of schizophrenia, or even hallucinatory delirium. There is a video here, which is pop culture and what pop culture. We made this video ourselves, and it's a pop culture. What pop culture says about loneliness, essentially.
Loneliness, being alone, the fear of being alone, is a huge part of what I am. At this grade school that I was attending, the teacher on Valentine's Day said, everybody send the people you like a Valentine. Everybody's going to get a Valentine. Some intuition, even as whatever I was, 6, 7, 8 years old, I sent myself Valentines, and those were the only Valentines I got.
America is an every-man for himself, winner-take-all culture that chews up and spits out people who don't keep up. You can fly as high as you want here, but if you fall by the wayside, our response is, sucks to be you, loser. Unfollow.
Being acutely lonely is as stressful as being punched in the face by a stranger when it comes to cortisol release, right? That's how deeply we are resistant to loneliness, right? It's a signal telling you to get back to the tribe. That's why we evolved. It's a really important signal. If humans hadn't had that signal, we wouldn't be here, right?
We're living alone. We're spending more time online and less time making meaningful in-person connections. So when emotional storms hit, things like losing a job or going through a divorce or a death, instead of leaning in towards our communities, we've learned to suffer alone.
Loneliness is as or worse of a health issue in our country than smoking. Heavily smoking. There's all this. There's this new
loneliness
isn't
overpopulation coincided with loneliness at the
think
same
about
time.
that. We're thrust further and further closer together, and
We don't know each other.
and we're more and more disconnected and lonely. And
You are confronting the dragon of chaos when you go into the social situation. And so what do? You're like this, right? You hunch over, and that's low dominance. I'm no threat. It's like, well, that's not going to get you very far. You know, but that's a logical thing to do in the face of a tyrant. So I'm no threat. You know, you look at the king and you're dead. I'm no threat. I'm hunched over. And then what's happening internally? What are people thinking about me? What are people thinking about me? Am I looking stupid? Am I looking foolish? Geez, I'm awkward. I hate being here. Man, I'm sweating too much. It's all internalized, right? It's all self-focused.
Sometimes when things clear away, you're not watching it, you're in your car, and you start going, oh no, here it comes, that I am alone, like it starts to visit on you. You know, just the sadness.
Yes.
Life is tremendously sad just by, being in it. And so you're driving, and then you go, that's why we text and drive. I look around, pretty much 100% of people driving are texting.
Yes.
And they're killing, everybody's murdering each other with their cars.
Yes.
But people are willing to risk taking a life and ruining their own because they don't want to be alone for a second.
So don't text and drive, no matter how lonely we get. All right, so we'll get Bavli to come up and speak about Stacy's story.
Okay, thank you. So Stacy, we'll introduce Stacy. So Stacy was a 22-year-old who came into the birthing center in the hospital that I work out in in Toronto. So she's a very fascinating case. I've used her in a lot of case studies. So she was actually on her way to an abortion clinic. And I'm not sure what the laws here are in Illinois, but in Canada, abortion is legal. So she was on her way. She was taking public transportation. When she was waiting for the public transportation, she ended up falling. She called 911, and automatically they took her to the closest hospital. So she delivered. It was declared a stillbirth at 20 weeks gestation. So she was already a mother to a 2-year-old at home. When I met with her, I only met with her once in the hospital setting. She felt guilt for abandoning the child. One of the major things that changed for her actually while she was there was hearing the cries of other children in the unit. So usually moms who have a loss, we try to keep them in a private room so that they're not hearing other moms and babies, right? Because that has a huge impact on them. And that definitely had an impact on her while she was there. Her partner, her husband, was not there at the time. He was working. She was very close with him, spoke highly of him. She also had, her parents were also in the picture. And a very interesting facet is she is Roman Catholic and very much connected to her faith, to her parish, and to the parish priest. She had a very deep connection with him. So a lot of things had come up while I was with her. One of the things that had come up was her parents. She was very much afraid of her parents, who kind of raised her in a very fundamental household. And so she was afraid of connecting with them and how they would feel. So a lot of that guilt, the anxiety, and the angst was also created into that as well. Another aspect was her parish priest. So when I met with her and she told me about her parish priest, I actually encouraged her to continue seeing her parish priest after she left. She had a very deep connection and very supportive of her. She didn't share much with me in regards to what he was sharing with her. He was aware, as she told me, aware of the abortion that she was planning to have. And Mina will look at more kind of the stats as to why people kind of think about abortion or are led to having an abortion. But one of the big things for Stacey was the financial means and taking care of the child. She said that she didn't have the financial means, she didn't have the time, and it was going to be very hard to raise 2 children who were both under 2 years of age. So that was one of the kind of the factors that led to her initially wanting to have the abortion, and then all these other feelings had come out while I met with her. And yeah, so I'll invite Mina back up and we'll continue our presentation.
So there was a study by Biggs and Company. It's called Understanding Why Women Seek Abortion in the U.S. And it was a good study because it asks 954 women open-ended questions about why they want to have an abortion. And you're allowed to choose more than one answer, and you're allowed to have it free text. So it wasn't limited to multiple choice, and this is what the author thinks that the reasons are, and pick one or pick several. So it was very open. They would categorize it after they would all put in their free text. The demographics, they found that most women who seek out abortions are mostly single, never married women. Less than half of them have a high school education. Just over half were employed. And the reasons ranged from financially to just not being ready. So more demographics. 79% of women were single and never married. 47% had more than a high school education. 60% had enough money to that month to pay basic needs. 45% received public assistance. 53% were employed. And 27% had a history of depression or anxiety. So what do you guys think the most important reasons, or the most important reasons why women would give to have an abortion? Lack of support? Sorry? Financial. Financial is actually the number one thing. 40% of women chose, women participants chose financial. Anything else? Okay. Yep. So not being financially able is 40%. Not the right time for the baby was 36%. I put that in quotations. Not the right partner was 31%, and that was further subdivided to, oh, the relationship is bad or poor and new, the partner is just the wrong guy. Surprising 29% said that they needed to focus on other children. And I saw this in clinical practice too. I had a patient recently in the past month who already had a child at home, and she wanted to have an abortion because it was overwhelming to take care of that child already. She wasn't in financial need. She had a husband at home. She had social support at home, but this would be her main reason if she was part of the study. Again, interferes with future plans, 20%. This is especially true, I think, in the younger population, especially women who are pursuing a career or pursuing college education. Health-related reasons were 12%. Some wanted a better life for the baby than they could provide. Again, that's an overlap with finances. Some were not independent enough or mature enough to have a baby. That could overlap with finances. And then influences from family and friends were 5%. So from the participants, they took a few of them and they quoted them verbatim so that they could further analyze or further show what they were going through. One 42-year-old woman said that the monthly household was a little over $1,000, and she says it was all financial. Me not having a job, living off of death benefits, and dealing with my 14-year-old son, I didn't have enough to buy a baby spoon. Another woman said that I already had 2 kids and it would be really overwhelming, and it's kind of hard to raise 2 kids by yourself. Very similar to the patient I had. And also Stacy's story as well. She had a kid at home. One woman describes, one 25-year-old says that we are not really sure if we ever want kids, and that she wouldn't be strong enough to give it up for adoption. There's an older study from 1997 which shows the suicide rates or admission for suicides in the hospital before and after abortion took place. The rate was 5, and then it rose to 8.1 after the abortion had taken place. And then the other 2 lines are for, for miscarriages, it actually decreased after the miscarriage took place, the hospital admission for suicide. And the other one was a normal delivery. Also, the suicide admissions decreased. And this is just the data on that. There was another study in China, in 3 major cities in China, that took a sample size of over 5,000 women who were migrant workers in China, and they found that induced abortion increases the odds of suicidal ideation in a female migrant worker. And this is a continuation. It shows that the odds ratio is about 1.89, and that's after adjusting for age, education, years in the workplace, tobacco use, alcohol consumption, daily internet use, attitude towards premarital pregnancy, multiple induced abortions, self-esteem, loneliness, depression, and anxiety disorders based on subjective surveys. And this association between suicidality and abortion increased when you took a look at the older women, age 25 or above, which increased the odds ratio to 3.37. Or if you took a look at the women with greater than 5 years of stay in the working place, or in women with the non-anxiety group, or the non-depression group. Another big study was a meta-analysis of 22 other studies, and they took 800,000 participants. 163 of them experienced abortion. And they noticed that 81% of that women who had an abortion had an 81% increase of mental health problems, and that nearly 10% of the incidence of mental health problems was shown to be attributable to abortion. There is a caveat, though, because there was another study that said that women who have had abortions versus women who have not had abortions, it's almost a similar rate of antidepressant use. But that could mean that we as providers are giving SSRIs very frequently, and to treat, baby blues or postpartum depression. So the cardiovascular effects of perceived social isolation, and again, perceived social isolation is very different than voluntarily going out and being isolated, like a monk, for example, because one is purposeful and one is not, or one is looking to get an objective of being secluded and being alone with God, and the other is just having perceived social isolation, whether or not you're alone or not. So they found that systolic blood pressure goes up when you're lonely. In terms of coronary artery disease, they did Lancet did a study called the Interheart study, and they took some 15,000 cases and 15,000 controls, and they found that permanent work stress is much more common in the cases that had myocardial infarctions, as well as general stress as well. So isolation could give you a heart attack. And then congestive heart failure also increases because hypertension and coronary artery disease contribute to CHF. Another smaller study took 75 medical students and took their blood a month before final exams, and then took another blood sample the day of their first final exam, and then they compared the two results. And as time progressed and as they became more stressed out, the number of natural killers, which is a type of cells in your body that fights viruses, cancers, and you name it, decreased very significantly, especially in those that scored high on anxiety scores. Loneliness also found to have an increase in urinary glucocorticoids, which basically means that you're more likely to have diabetes if you're lonely, because that's the stress hormone and that causes your sugar to go up. Another study for people above the age of 70 found that the processing speed is significantly altered when you have low social support or perceived social isolation. And then, of course, the typical suicide rates increase, depression increases, and anxiety increases when you're lonely. This is Saint Rita of Cassia. She is an Italian Roman Catholic saint who is the patron saint for loneliness, or for lonely people. She was married at a very young age to an immoral man named Paolo Mancini, and she experienced loneliness in that she was abused by her husband, both physically, verbally, and emotionally. And then she had her first child at a very young age of 12. Her two sons were Giovanni and Paolo. And, And then she had, her sons died of dysentery, and her husband died because he was murdered by a family feud. So she ended up on her own, and then she went to the convent to become a nun, but they refused her because she was associated with all this rival gangs, Italian mob sort of picture. And then they later found that she was she was a devout woman, and they accepted her to become a nun. She later died in the convent of tuberculosis. The reason why she's the patron saint is because she continuously had this issue of loneliness, both when she was a young child and got married, and afterwards when she became right before she became a nun, she was refused from the convent as well. This is Saint Porphyrios. He is a hero monk from Athos, as you may know. And he was also a chaplain in World War II. And he said something, when you find Christ, you are satisfied, you desire nothing else. You find peace, you become a different person. You live everywhere, wherever Christ is. You live in the stars, in infinity, in heaven, with the angels, with the saints, on earth with people, with plants, with animals, with everyone and everything. And then he says, when there is love for Christ, loneliness disappears. You are peaceable, joyous, and full. And so Saint Porphyrios' solution to loneliness is the love for Christ. And this is what His Grace was saying yesterday. He said, when you go off into the desert on your own, for example, you are actively seeking out Christ. And it is not a perceived social isolation, it is a desired isolation. It's a voluntary sort of thing.
Thank you. So, by a show of hands, have we all heard of Carl Rogers? Yes, Carl Rogers, very famous psychologist. Okay, great. Freud, Viktor Frankl. Yes, okay. Man's Search for Meaning as a classic. I highly recommend that for a read. So now we're just going to move over now. So we got the kind of the medical background, the stats and everything, and now we're just going to move into the other aspect, which is me being a chaplain, a spiritual care provider. How do we address loneliness? And it might come as a surprise, but it's by being together, right? By being with each other, by being in community, right? By engaging in different aspects is how we address it. So why is Carl Rogers very famous in the world of psychology? So himself, Viktor Frankl, and everyone else came after them in World War II. One of the major shifts that happened in psychology was the client is the one who became the owner of their own issues and problems. And that is essentially kind of the foundation of his theory, which we will unpack, right? And this was revolutionary because you went from Freud, who didn't even look at the patient, or the client didn't even look at Freud. He used to sit behind him, I believe, if I'm not mistaken, right? To now the client is the one leading the sessions and the therapist is just sitting there kind of directing and asking questions, right? So he had this quote up here. So he said that it is the client who knows what hurts, what directions to go, what problems are crucial, what experiences have been deeply buried. It began to occur to me that unless I had a need to demonstrate my own cleverness in learning, I would do better to rely on the client for the direction of movement in the process. And that is essentially the kind of the paradigm that he worked out of. Right. So before we get into that, right, just a little bit of a history. So his theory, Carl Rogers, is, person-centered therapy, but it's all related to the humanistic psychology and the existential therapy, which was made very famous through Viktor Frankl's logotherapy. Right. So when we look at the existential therapy, right, what does it say? It says that the world lacks intrinsic meaning. The individual is faced with anxiety of creating their own identity. Right. So there's a focus on the harsher realities of the human experience. Example, death, meaninglessness, and isolation. And for someone, say, like Viktor Frankl, right, it was the Holocaust, right? Being in a concentration camp, he had to find ways to, with the community that he belonged to, how to escape that or how to survive that on a daily basis, right? In Man's Search for Meaning, he used to give stories where one day, one of his brothers would be a little weaker. So he would take his portion of the bread and give it to him. And then another day he would be on the weaker side and then someone else would give him his portion of the bread, right? And that's how they came together. Humanistic psychology, right, which is a little more hopeful, has a more hopeful view of the world, says that the individual has the natural potential that can be actualized through which meaning can be found. And then person-centered therapy, right? Very much taking a lot of material from the humanistic psychology, says that individuals are essentially trustworthy. Individuals have great potential for understanding themselves and resolving their own problems without direct intervention from the therapist. And individuals are capable of self-directed growth if they are involved in a specific kind of therapeutic relationship. So, what does that mean? How does that look like? We're going to unpack that right now. So the first question that Rogers asks is, how are the problems defined? Right? What are the problems and the issues that the client and the patients are facing? Right? So rather than seeing people as being flawed, person-centered therapy identifies that each person has the capacity and desire for personal growth and change. So when we look at Stacy's story, right? Stacy's story, with her example, right? She already knew what was going on. She knew that she wanted to have this abortion and that, she didn't make it in time to the clinic and she was admitted into the hospital. Right, so she already knew all that was going on, and she felt the guilt, maybe a little bit of shame, right, with the feelings and the emotions that she shared. She already knew what was going on, right? So there is part of the problem for her that's defined. right? Rogers termed this natural human inclination, actualizing tendency, or self-actualization, which he actually stole from Abraham Maslow's hierarchy of needs. So Rogers said that individuals have within themselves vast resources for self-understanding and for altering those self-concepts, basic attitudes, and self-directive behavior. And these resources can be tapped if a definable climate of facilitative psychological attitudes can be provided. Very simply put, he said, us as the human being, not only do we know the problems in the issue, but we also have the capabilities to find the solutions and to grow from them. Right? How is change possible? Right? So facilitate personal growth and development, to eliminate or mitigate feelings of distress, to increase self-esteem and openness to the experience. Right? And so with Stacy, I was able to create a safe space with her to allow her to be open to the experience and to talk about it. Right? She was very hesitant initially to wanting to talk to me when it was introduced to her that, a chaplain will come and see you. But then when she started opening up to me a little more, then she started to realize that this was a safe space, and she started to unpack that experience a lot more with me. Right? Enhance the client's understanding of him or herself, greater agreement between the client's idea and the actual self, better understanding and awareness. Right? And then there needs to be decreased defensiveness, insecurity, and guilt, greater trust in oneself, healthier relationships, and improvement in self-expression. I encourage you all, whenever you have the time, Carl Rogers has a very famous counseling session that he did in 1965. It's on YouTube. I'm forgetting the client now, where you actually see the client kind of unpack her experience, her feelings and emotions. And while she is sitting in the therapy session, she realizes, oh, wait, this is all because of me. Right? And he's not saying a whole lot. He's just facilitating questions and discussion for her to share her experience. But I encourage you all to check that out. Right? So what is my role? What is your role? What is the role of the therapist? What is the role of the chaplain in this? Right? So first and foremost, we have to be honest with ourselves. Right? We have to be very open to our own experience. Right? When we look at Freud, right? Freud was always, he wrote that as a therapist, we always have to be guarded. We can't share personal experience. We can't open up with the client. Whereas Carl Rogers, Viktor Frankl, and everyone else who came after World War II said the complete opposite. They said, no, we need to develop a relationship with the client and the patient. Right? How are we going to open up ourselves to them in order to facilitate dialogue and conversation? So the counselor needs to be genuine and is aware of their own feelings. The counselor has an empathetic understanding of the client and his or her internal framework of reference, looks to communicate this experience with the client, and the client recognizes that the counselor has unconditional positive regard for him or her and an understanding of the difficulties that he or she is facing. So going back to Stacy, right? For me personally, I had no way of relating to the experience that she went through. Right off the bat. I had nothing to relate to. But the one thing that connected us was the spirituality, right? It was the religion piece, right? And she was always used to people judging her, right? And so my role there is I did not judge her. And she was very much taken aback by that, right? I allowed her to share her story in a way that, she wanted to. And without throwing any judgment on her, she was able to express herself and to share very openly. And so these are the 3 points, the essential points in Carl Rogers' theory, right? So the first is congruence, right? So being genuine and authentic. The second point is unconditional positive regard. So accepting, respecting, and caring for the client. And finally is empathy. So understanding the emotions and everything that is taking place with the interaction that you're having with the client in the therapy session. So those are the kind of the crux of his theory. When it comes to providing therapy and support. So, how does the intervention look like? What is the therapist doing with the client in order to facilitate dialogue and interaction? So, the first approach is non-directiveness, right? So, allowing the client to drive the therapy session, right? You are not allowing your own biases, no matter what that is coming up, to drive the session, right? Everything is based on the client and the patient, right? Reflection of feelings, right? So repeat back to the client feelings that they are sharing. Oh, I hear sadness in that. I hear a lot of anger, right? So repeating back the feelings that they are sharing, right? Asking open-ended questions, right? How does that make you feel? Paraphrasing, and paraphrasing is very important to repeat back the words that they are sharing, right? That's an indication to the client that you are listening to them and that you are actually engaged with them, right? And lastly, to be an encourager or a facilitator, right? So you say things like, what else? Please go on. Tell me more about that. These are some ways that the intervention will look like. So, Carl Rogers, what is his background and how did his own upbringing influence this theory and this modality that he developed? So he grew up here in the States to a very strict version of Protestant Christian belief. He actually decided to become a minister, and he chose a very liberal seminary to attend. I believe it was Union Theological Seminary that he went to. But I don't know how far along he got in his studies, but he essentially did not want to study anymore, or he didn't want to become a minister. And he actually left the seminary. And he actually did stop believing in the Christian faith altogether. He considered any form of religion incompatible with his own philosophy of life. And he never used the word religion in any positive way in his work. And it was only towards the latter end of his life that he began to use the term spirituality. So how does this spiritual background influence his theory, right? So he said in 1980 that I found that I had embarked not on a new method of therapy, but on a sharply different philosophy of living and relationships. So Rogers' approach can be regarded as a practical philosophy of living, aiming to liberate people from authoritarian dominance, including that of religion. His approach contributed to the quest for life's meaning for those who do not want to lose spiritual dimension in their life. And life's meaning has to be found in life itself, and his therapy is directed at the goal of living life to the fullest. A very important contrast between Rogers and Freud. So Freud altogether, threw out religion. He said, he didn't like religion. He said religion is useless and it has no place or meaning in the therapy session. Contrast to Rogers, he also did not like religion, but he never influenced his clients or his patients in regards to the use of religion. If that was something that is important for them, Rogers unpacked that and explored that with them, right? And that was one of the big differences between Rogers and Freud with the use of religion. So, as we mentioned earlier, person-centered therapy depends on seeing the individual as trustworthy, capable, with a great potential in understanding themselves and work on their own problems if they are engaged in an honest, encouraging, and affirming therapeutic relationship. Some Christians might find it contradicting to their core Christian beliefs and how they adopt theologies of sin, salvation, free will, etc. However, other Christians might find it affirming to the power of God that works within and appreciates the transparency, non-judgmental, and affirming values of person-centered therapy. And so, what does this all mean? By way of conclusion, and the questions that I ask myself every time to kind of keep me in check, is what does it mean to be a human, right? What does it mean to be human in the world that we live in today? Another author I would highly recommend who unpacks this question is Father John Baer. I studied at St. Vlad's under him, and he impacted my own theology and my understanding of what does it mean to be human. So I encourage you to read some of his works where he unpacks this. But of course, St. Irenaeus of the 2nd century says, our Lord became what we are, that he might bring us to what he is himself. St. Athanasius, for he was incarnate, that we might be made God. And Midnight Praises in the Coptic Rite, which is this particular one, which is chanted on the Friday. He took what is ours and gave us what is his. We praise and glorify him and exalt him. Ultimately, it's finding union in God, finding union in Christ, right? How does that look like? How does that play out in all that we're doing? Not just our work and studies, but in life with each other as we get to know each other and as we live in community. And I think that's kind of just unpacking it in the bigger picture. Any comments or questions? I think we have
time for questions.
Yeah.
Are there any questions?
Is there is there a difference in, so I know it's hard to evaluate, is there a difference in abortions Canada versus United States. Canada has a wonderful maternity-paternity plan that we do not have here in the United States. And much more, I think, much more support. Does that factor in with the loneliness or isolation, reduced loneliness, isolation, or maybe even reduced, it's hard to factor it because it's legal, but reduced abortion?
Yeah, so I think you're right. I think that it would reduce the loneliness. Yeah, you do have a good point. I find when I have patients that are requesting abortions, I personally don't. I mean, I'm not equipped to do that for them, and I also don't want to do that for them. That's not my place. But I'm obliged to give them resources to places in Ontario, so that they can do it. They do have support systems. They do have ways to kind of combat their loneliness. There is a lot of psychotherapy. Unfortunately, the wait times are high because there's such a high demand. And I remember with one patient, I saw her and her boyfriend. This was in a walk-in clinic in downtown, back when I was doing walk-ins more frequently. And her boyfriend was very keen on aborting the baby. He said, listen, we can't keep it. We got to get rid of it and whatnot. But she was on the fence. And I kind of told her, I mean, this is entirely up to you. I mean, it's, I couldn't tell her what to do, but you have to think about it. If you're on the fence, you have to give it some thought. You have to say, okay, what are the things that make me want to keep the baby? What are the things that make me not want to keep the baby? And think about it. And I told her that I was one of 3 children, and I'm the youngest one of the 3 children, and I was an unplanned pregnancy. But of course, my mother didn't consider, because of her, background in the church. Also, it's in a third world country in Egypt, so I mean, that's not a thing. But I told her, I have a very good relationship with my mother, even though I was not necessarily planned. But that's, I mean, we get along very well, and that's something to consider too. And by the end, she was kind of like, okay, well, I have a lot to consider. So I was obliged to give her the resources to get to like where to go to get an abortion. But I also gave her a prescription for prenatal vitamins and prenatal labs if she did choose to keep it.
Actually, the first question, actually 2. The first question was Man's Search for Meaning with Viktor Frankl is just an incredible book. It's a classic. And, I always, as a physician, I always wondered, I sit with patients for an hour and a half my first visit. That's how I care for patients. And one thing I've, through 13 years of doing functional medicine, I've noticed that I've wondered why some patients with the same issue get better and some don't. And I came to a conclusion after 13 years of doing this in thousands and thousands of hours. Those people that have a sense of God-given authentic purpose tend to get better. And those who live in dramas and, they don't have that sense of a purpose on this earth, they tend not to get better. And I'd like you to just comment on that idea.
Yeah, so I absolutely agree, because it's the same thing with chronic back pain too. So with people for chronic back pains, it's called a yellow flag. Basically, it's their perception of their back pain. Do you feel like you'll ever get better? If they say yes, then chances are they're more likely to get better. If they say no, I'm going to live with this pain forever, then they're going to remain to have it. So there's much truth to that, absolutely. It's kind of we showed a slide of a video of Jordan Peterson, and his whole mission is to kind of get people moving and kind of like help yourself sort of thing. And that's very true. Like, for those who are willing to help themselves and push themselves and realize that no one else is going to push you, most probably, then you need to push yourself in order to get better. So yeah, I agree with that 100%. Sorry, did you have a second question?
Yeah, it's actually, when you talk about extroverts and the idea that they have more sense of loneliness, the idea of putting them in the situations where they're stimulated more with more communion with others and all that, wouldn't it be the opposite where you want to teach them more techniques for dealing with themselves while they're alone, as opposed to constantly keeping them in a stimulated state so that
Oh, yeah. I agree with you. I agree with you. That slide was just to show that they are at risk of feeling, of perceived isolation. But yes, the best thing would be to teach them to how to deal with being alone. It's easier said than done, but yes.
Okay, so on the topic of teaching someone how to feel okay about being alone, which cards on the table, I think it's insane.
Right, it's difficult.
As Orthodox Christians, what is our obligation to the person who will never become Orthodox, who will never maybe become a Christian or have any positive things to say about faith, who is acutely lonely and still made in the image of God? What is our responsibility to them?
Well, I think Bavli touched on the psychotherapist's role, and it's essentially a counseling session. To provide counseling, even as the Orthodox faithful, whether or not your friend is Orthodox, you're still able to have a conversation with them and to listen to them. There's no magic pill for loneliness, even though they're actually working on it. It's called pregnenolone, which is it's a precursor to steroids in your body, like testosterone and progesterone and whatnot. It's still in clinical trial, but I don't think that's the right approach. Like we don't need to medicate the community just so that we don't perceive loneliness. The right approach would be to talk to one another and communicate with and build a community that would combat loneliness. I mean, in order to connect to somebody, you have to connect to somebody. There's no other way. Do you have anything?
Yeah, and you're absolutely right. I don't think there is an answer to this. I remember when I first started out my chaplaincy career, I was, very hot. I'm going to go in and I'm going to solve everything. And then I actually started realizing there is no solution, right? So to see people, especially who are not Christian, I explore things that give them meaning, especially I would say some of the best conversations I've had are people who identify as agnostic or atheist. And I try to find out what gives them meaning, what gives them hope, what pushes them, how do they wake up every morning, right? What is driving them? And I explore those things with them. And just kind of, we bounce ideas, and that's what it is. I don't think there is a solution, but constantly being with each other and not being isolated, right? I think isolation is the worst thing. And going back to the extrovert thing, right? We always think of extroverts as being the happiest people, when in reality they're probably not, right? One of my favorite comedians, Robin Williams, right? Took his own life, and when you look at someone like Robin Williams, you think he's the happiest person we know. But he was battling so many addictions, from drug to alcohol and everything else, right? So I think being with each other and just exploring what provides meaning, and pushing people in that direction and helping them in that direction is one way. Where that leads is to be determined.
Thank you guys for a great presentation. It was excellent. I really enjoyed it. The comment I wanted to make is regarding that question about how do you apply Christian principles to people who aren't Christian. And I think it's aligned with the connection between Father John Baer and our understanding of kenosis and Viktor Frankl, who's not Christian. And they're commonly quoted together, and Orthodox people love Viktor Frankl and love the idea of having meaning through suffering. So sometimes people will react to a certain lens that we bring, but the lens is not the tool. The actual concept itself, and if we talk about love, or if we talk about meaning, or if we talk about suffering, or if we talk about these concepts themselves without presenting the lens, then it's sometimes a little bit more palatable to people. So your comments about I'm going to go and I'm going to fix them, but drawing out from them what's meaningful to them, that is where we can potentially identify Christian principles. So if we're listening for that, we're listening for something that we understand from a Christian lens, and we say, okay, well, I'm never going to bring up this word because then they're going to associate it with some church or some pastor or some person that they don't like, and that's totally okay. I don't need to trigger them in that way, but being able to draw out the concept from themselves so that you're not the one saying it. You're not saying, oh, well, that's kenosis, or, this guy, Father John Baird. No, you don't necessarily do that. But if it's coming from them, I don't really think that any of these things are that so fundamentally difficult conceptually. Like, there's a difference between something being hard to understand versus hard to live out. Some of these things are very simple to understand, but they're just hard to live out. And when someone is able to come to a realization, like you were mentioning the video of Carl Rogers, like interviewing that person, like, if the person just comes to that realization themselves, and we don't have to say very much, again, it's a very simple concept to understand, but then they have the opportunity to kind of live it out without us necessarily telling them what to do.
Yeah.
We have time for maybe one more question.
Thank you again for your talk, for the presentation. There's a new book out called The New Media Epidemic. It's from Jordanville Press. Fantastic book, just fantastic. And one of the things that's pointed out is social media use and smartphones, frankly, our reliance on them. There are a lot of, in your causes, in the first couple of slides, social media came up a number of times. Without being, absolute Luddites, how do we deal with that? We're foisting our kids, foisting these things onto our kids, and they become more and more, reliant on fake relationships, and then they grow into a culture of loneliness. Can you say something on that, please?
Yeah. It's not just the kids, actually. So I was actually listening to the radio, and they were talking about the number of times that the kids are telling the parents to put their phone down and so they can get attention is very, very high. So it's not just the kids. We're teaching our kids through example, and then we complain about them being glued to their phones as well. So that it is a very, very difficult thing. Like it's something that, I don't have children, but I know it's easier said than done. But I would very much be against them being on the phone. Sometimes you see people when I need my phone to feed my kid. When they're eating, they need to watch something or else they're going to be misbehaving. So that's I completely disagree with that. That's going to be a disaster in the future, because then they're going to have A, bad posture, and B, they're not going to have any social connection. They're going to be good. And it's very difficult also from like a husband and wife perspective. Like, try to have a conversation with somebody who's glued to their phone. It's impossible. Yeah.
And just a few things on that as well. So the other day I was at the bank. I was actually taking out money so I can bring it here. And literally I'm seeing two kids, a mom and a dad, maybe three people behind me. Mom and dad are on their phone, and the kids are pulling on them, saying, they want it to be lifted, right? They maybe look like they were 3 or 4, and they're both on their phones and paid them no attention. So it really is becoming an epidemic. I would say one thing is to work with our community leaders to continue to help our kids in this direction. So one thing that we've done in Toronto is, I forget which board it is, if it's the Toronto Public or Catholic board, where they've banned cell phone use during class time, right? Kids are having cell phones. That is a reality, right? And they'll let them maybe use it during recess or whatever. But during classroom settings, they've banned cell phones. Kids were using them. So continuing to work with the community and the leaders and the people who are interacting with our kids to see what can be done. And parents need to, I don't have kids, so I don't know. I'm not an expert and I can't speak to it, but setting limits maybe, or just, I don't know, just allotting different things, because this is the reality that we are living in. Technology and social media is something that is part of the society that we are in. So setting limits, or what outlets, this is what I've seen other parents do, what outlets their children can have access to and not have access to, and hope for the best. I don't know.
As a family physician like you, there's the opportunity at the pediatric well-child visit. I mean, that's become part of what I talk about with the families, and sometimes that comes as a surprise. And then the number of times it comes up, not just with concerns about social interactions, but sleep issues, headaches, other things. So that's another opportunity for us to kind of engage the parents and hopefully educate. But thank you so much for just a wonderful